Hello and welcome to Creighton in the Community. It's been 26 years since I delivered my son, and things have certainly changed. Today we're going to visit the newly remodeled labor and delivery and patient rooms at the Creighton University Medical Center. I'm with Dr. James Smith. He is the chair of obstetrics and gynecology at Creighton University Medical Center. You are new to Creighton. What brought you to Creighton?
I saw here great potential to take over a department that has been traditionally very strong in training medical students and in clinical care. The opportunity arose for me to take over the reins, and I hopped on it pretty quickly. After a few visits here, my wife and I love Omaha. We love Creighton. I feel like I've hit a home run professionally.
Well, good. It's nice to have you here. And there have been many changes that have occurred on this floor as we've walked around. One of the big changes is out in the nurses' station. Talk a little bit about the changes out there and why they're important.
Well, we have always felt that the quality of care here has been outstanding, and it's very important that the atmosphere of care match the feeling that the nurses and the physicians and the learners have as they care for patients here. So over the course of the last year, designs were made, and we have recently completed a very nice refurbishing of the equipment that we have, as well as the atmosphere of care. We have new paint, we have new floors, the nursing station has been redone. We're very proud of it.
It's very nice. And where we are right now is in one of the birthing rooms, and been a long time since I delivered a baby, and many things have changed. Tell us a little bit about what's happened. I know what happens in this room, but what makes this room unique and why it's such a good place to deliver your baby?
Joyce, yeah, it may have been sometimes since you have delivered, but the birth process remains natural. Many of the elements, but remain the same. Babies have to come out. Our job is to make sure that we take all of the contemporary sciences and equipment that we have and assure that that process is safe. In this room, this is a very typical labor room. We have monitoring so we can keep track of the fetal heart rate and how babies are doing during the process of labor. The monitoring is centralized so that the nurses and physicians caring for patients can see the monitoring at the nursing station when they're not here in the room. This room is very nice. We have windows, it's sunny, and we hope that it matches the birth experience that our patients expect when they come here.
Well, 26 years ago when I had my last baby, there are two things in the room here that weren't there when I had a baby. One is really comfortable furniture for the visitors that they're like my husband and family. Why is it important to have this family friendly room?
With modern obstetrics, we've recognized the need for support for women during labor, and that support comes from family. This is our family birthplace. We want to make sure that family members supporting the patient in labor are comfortable and are welcomed and feel like they're part of the care team. Now,
after the baby's born, then the mother is taken to another room, correct? Or does she stay here the whole time?
Depending on the medical condition of the mother, some mothers will stay and recover in this room for some length of time. We have a postpartum floor that's very close. It's right outside the door and down the hall. And the level of care for the patient that's recovering well is different than the intensive care that's necessary on labor and delivery.
Let me ask you, you mentioned the different levels. What are some reasons that the mother would stay here versus go to postpartum versus go to a room? Is it because of complications or?
There are some complications that can arise during labor. Many of our mothers that we take care of are high risk to begin with. They have medical complications of pregnancy, such as high blood pressure, diabetes. Some have some very significant multi-organ medical conditions for which the postpartum recovery is extended.
And that's when they would move down to the other.
they would stay here for initial supervision, and then once stabilized, they would move to a separate area for continued recovery.
Now, this may be a misconception on my part, but I have seen rooms, not this one, but has tubs in the room. Are the tubs for the labor and the delivery both? What are those tubs for?
Well, part of our remodel process included an assessment of what might assist with the birth experience for mothers, and one of those that we came to the decision for is a large tub for laboring patients. The tub is filled during labor, and patients can immerse themselves in this during the labor process. We think that buoyancy supports the mother's back, may relieve some pain, but offers an alternative experience to the typical birthing experience, which traditionally has just been in beds. The birth does not occur underwater. Still, the birth of the child occurs in the bed. But during the labor process, we feel excited about this enhancement of the experience for some patients. The response we've had has been very, very positive for those patients that have chosen this.
One of the other things I heard someone mentioning about was the wireless fetal monitoring. I don't know if I had that or not. I'm assuming I didn't, since this is a new enhancement. What does that involve?
Well, one of the main methods of making sure that the baby is safe during labor is by fetal monitoring. And traditionally, the monitors have had wire connections to from the patient to the machine, upon which we make interpretations of the heart rate strip. So here at Creighton University Medical Center, we have monitors that attach to the patients, but are wireless. So the information is transmitted wirelessly, allowing the patient to ambulate, to walk around.
Right.
They can be in the room, they can be out in the hall, and patients perceive that very favorably. So although we continue to monitor the patient is not limited to just remaining in bed next to the monitor connected by wires.
Another big change in 26 years is that this little baby would be miraculously rolled into my room. I'd feed the baby, then it would be miraculously moved back to a nursery. And as I've noticed, is the nurseries don't have babies in it. The babies are in the rooms. What's the reasoning behind that?
Well, Joyce, you might have noticed with the recent delivery of
my grandson.
Your grandson.
He was in there the whole time too.
Other changes have included the length of stay that mothers are in the hospital as well. Our whole concept of the postpartum recovery evolves as time goes on. Recent studies have shown that when the babies stay with the mother, even immediately after delivery, that the sleep cycles of the mother are enhanced. The mothers actually get more rest when they're with the babies in their room. So as we collected this type of information, we apply it to the patients that are here. We want to make sure that their experience is phenomenal, and that they feel well supported for the time that they're here in the hospital.
But I also know that if the mom really needs a good sleep, that the baby can go to the nursery, and that's good. Although I think you're exactly right. My daughter wanted that baby right there beside her.
And that's what we want for the patients as well.
The education of how to take care of that baby began right away. I noticed with my daughter that the nursing staff immediately comes in and starts educating the mother and the father on how to feed the baby, care for the baby, bathe the baby. And that also is important, I assume.
It's very important. In fact, we try to begin that education process even before our moms show up in
how's
labor.
that?
Well, early in prenatal care, we begin to talk about issues that are going to be important for especially new parents that have not been through the process of early parenting to begin with, such as the importance of car seats, the importance of breastfeeding. That education begins early on. Obviously, our nurses are amazing educators, and that supplies the most immediate information for patients when they have their children in the hospital.
After the babies are born and after they have gone home, can new moms keep calling back here and getting assistance if they're not sure what to do?
And in fact, we know that they do. They call labor and delivery, they call their primary physicians and providers, and the lines of communication are always open.
Well, this is an amazing place. Thank you. And now we're going to visit with Dr. Chris Glowacki, another obstetrician and gynecologist with Creighton University Medical Center. I'm here with Dr. Chris Glowacki, an obstetrician and gynecologist with Creighton University Medical Center. What is the difference between a gynecologist and an obstetrician?
Well, obstetrics and gynecology is the overall field that encompasses the complete span of women's health care from the reproductive years all the way through menopause and beyond. It's divided into several subspecialties, some focusing specifically on gynecologic care, others on obstetrical care. In general, when you see an OBGYN, it's a physician who's trained who can take care of multiple aspects of women's lives, and from, again, managing labor to managing menopause, providing surgical services like a hysterectomy. And then with subspecialties, you have specialists in the field of obstetrics, for example, who are maternal fetal medicine specialists who've gone on to do additional training to specialize only in antenatal and perinatal care.
Let's talk about that. What's the difference of those?
Well, again, with a maternal fetal medicine doctor, they're going to be somebody who sees specifically high-risk pregnancies, who manage the care of a patient with various pre-existing conditions, for example, hypertension, diabetes, and manage your pregnancy from the very beginning up through the delivery of the baby. And then you can talk about, in terms of gynecologic specialties, there's specialists who do additional training to specifically manage gynecologic cancer, for example, or even gynecologic problems like urinary incontinence, pelvic floor dysfunction, and there's specific surgeons for those subspecialties as well.
That's interesting. Why did you want to become an obstetrician and gynecologist?
Well, quite honestly, I always thought I'd be a family physician. I'd grown up and worked with them pretty closely, and then I actually, in medical school, got exposed to surgery, which I really liked. But I found that when I did OBGYN, it provided the best balance of having both continuity of care with your patients, that you're going to know them through pregnancies and beyond, but also having the ability to provide surgical and kind of hands-on procedures for patients as well.
So ideally, you would like your patients to come to you before they are pregnant and then take them through the pregnancy and then go into the sunset years, just like somebody like myself.
Yeah, I mean, that's really kind of the ideal relationship you'd have with your OBGYN. It's somebody who can provide care throughout your life. And specifically when it comes to pregnancy, it's always good to be connected with an OBGYN before you even consider pregnancy, because we know that pregnancy outcomes are much better if you can prepare and have good preparatory care before any kinds of pregnancy occurs. More often than not, people get pregnant without planning, and that there's no problem with that, but it's always nice to have that kind of preconceptual care that you can get from an OBGYN.
So if you are seeing a primary care physician or a family practice, once you get pregnant, is the recommendation then is to start seeing an obstetrician?
Not necessarily. Several family physicians do provide antenatal care and do deliveries. One of the advantages of going with an obstetrician gynecologist is that we've been trained to deal with more high-risk pregnancies or complications of pregnancies that other physicians may not feel so comfortable with, as that is, half of our specialty is the obstetrical portion. So, we've spent years in residency and beyond to get the knowledge that we need to have to manage these kind of high-risk situations.
And this might be a loaded question. Are you seeing more high-risk pregnancies now than you used to, or is just the awareness there of high-risk pregnancies?
I think it's a combination of both. I think that certain pre-existing conditions that can complicate pregnancy are certainly being diagnosed at an earlier stage or more often than not. Also, I think that there are certain conditions out in the world now that we're seeing an increased prevalence of that do complicate pregnancy in significant ways. Diabetes is a big one, for example. Certainly being pregnant there's always a risk that you could develop something like a gestational diabetes. Essentially, a pregnancy is a condition where people are relatively insulin resistant, and this is by design so that the fetus has enough nutrition. But some people's bodies can't sometimes overcome that, and then essentially they develop diabetes. We also know that this kind of pregnancy unmasks a predisposition towards diabetes later in life. So certainly with the increase of things like type 2 diabetes, there's certainly more pre-existing diabetics out there, and people who are at higher risk for developing diabetes later in life, and then putting them in a situation like pregnancy really shows that predisposition coming through.
My daughter just had a baby, and we were all very alarmed to find out that she had gestational diabetes. And frankly, the diet she went on was an excellent diet. I mean, I think it made her healthier, but it came as a real surprise. She did not have, you know, stereotypical things that I thought of, but I know that was, and at that point, she moved to under the care of a high-risk physician.
Correct. Yeah.
And the baby was delivered, and he's just fine. Let's talk a little bit more about some of the high risks. What are you mentioned diabetes? What else could cause someone to be considered a high risk?
Another big one that we see in our field is hypertension, whether it be pre-existing or hypertension that develops. So high blood pressure, essentially.
High blood pressure.
Yeah, I mean, there's again, with increasing rates of obesity and diabetes, hypertension is certainly more prevalent in the younger population, as opposed to it used to be thought of something that you wouldn't really be at risk for until you're in your later decades of life. But you know, we certainly see more of it, and certainly there are certain aspects of pregnancy that are hypertension related when you start talking about things like preeclampsia, which is certainly.
And that is?
It's a condition in pregnancy where you have hypertension. The exact cause is still a little nebulous. It has to do with placental implantation, but it's one of it's a condition in pregnancy that we watch out for, because when it becomes more advanced, it predisposes towards seizures and poor fetal outcomes. And
is it more harmful to the baby or to the mom?
it can be harmful to both. In preeclamptics, there's certainly the possibility of poor fetal growth, or again with placental abnormalities, increased risks of stillbirth. And then when you start thinking about risk of seizure in a mother, that can actually cause long-lasting neurological problems. With the high blood pressures you see in that situation, you can have higher risk for stroke. I mean, it is certainly what we consider a high-risk situation.
High risk. When you're under the care of a high-risk physician, or you have a mom that's high risk, you see the care more frequently, you're more closely monitored? You and I just walked down the hall and you showed me a preterm room. Tell me what a preterm room is.
Well, again, when it comes to, for example, preterm labor, or if people's water breaks early, which we call preterm rupture of membranes, you know, it's a situation where people need to be in a facility that can better monitor them, has NICU facilities available to a sufficient degree to manage early pregnancies. And because of some of the monitoring and things that we do in preterm labor, you really need to be in a facility where you can be watched closely in a hospital situation versus just at home, and that's why we have kind of the facilities that we do here to manage those situations.
We're seeing a lot more multiple births these days. Are they automatically considered high risk or not necessarily?
It really depends. Multiple birth, there's a number of different situations within the overall milieu of multiple birth. Certain sets of twins are higher risk than others because just the configuration of the placenta and the membranes on the inside. It doesn't necessarily mean that you have to go see somebody like a perinatologist just because you have twins. Certainly, I'd always recommend being under the care of an obstetrician gynecologist. Again, with twins, there's always the potential that they may be facing the wrong direction, or again, in some of the more rare subtypes of twins, you know, there are certain conditions that really need to be managed by a high-risk doctor because there's higher risk of, again, stillbirth and poor fetal outcome.
Now I'm going to stop you and ask you the question. You said perinatologist? What is the difference between a perinatologist and neonatologist?
So a perinatologist would be similar to when you talk about a maternal fetal medicine specialist, who is, again, an obstetrician gynecologist who's gone on to subspecialize specifically in antenatal and perinatal care. When you talk about a neonatologist, that's essentially a pediatrician who's subspecialized in the care of early
Itty
pregnancy.
bitties.
Exactly.
So I am assuming one of the values of really coming to Creighton and coming to this birthing center is you've got a whole team of folks.
Correct.
And so when you would start with your gynecologist, then you would go to your obstetrician, then possibly to your
Perinatologist.
perinatologist, then to the neonatologist, and you're all working together during this time?
Yeah, it's a big team environment, and that is really one of the advantages of being in an academic center like Creighton, is just you have several departments with several subspecialties that all work collaboratively to provide the best care that we can. And again, when you think about things like a neonatologist, it's not simply even just early babies. There are certain situations, even in term pregnancy, where you need the aid of a good NICU and a good neonatologist, which we have both here.
Yeah, I learned that unfortunately too with my grandson. He needed a neonatologist right after he was born. The other thing that we hear about, I'm hearing more about than, I mean, it's been 26 years since I've gone this route, more and more cesareans. Why is that?
Yeah, there's a number of reasons. Some of it is elective in nature. Some of it has to do with the increase also of inductions, which in certain situations can increase your risk of cesarean section. There is some hesitancy on the part of patients and certain doctors. Nationally, I'm speaking, as far as things like operative vaginal delivery. We're speaking of things like a forceps delivery or a vacuum delivery, where, again, in certain areas in the country, these just aren't performed anymore. So your alternative is really a cesarean section if there's an abnormal labor process. So, I mean, there's a lot of reasons the numbers have been going up. Part of it too is that, once people have had a cesarean section, in most situations you are able to labor, with a subsequent pregnancy. However, that's also up to the mother. If they wanted to have yet another cesarean section, that option is also available to them, which is probably, leading to the increase in numbers that we've seen as well.
And again, I'm sure you play a key role in helping that mom decide what's best for her baby.
Right. I mean, everything has its own associated risk factors, and it's just important that you have a physician who can clearly tell you what exactly the risks you're looking at in a situation of trying trial of labor after a cesarean versus a cesarean section. So just you have all the information there to make the best decision for both you and your family.
Thank you. Holding a newborn in your arms is truly one of God's finest blessings. Creighton University is committed to provide you wraparound care for your newborns. If you're interested in making an appointment with one of Creighton's physicians, please call the number on the screen. On behalf of all of us at Creighton, thanks for watching.